This hepatitis B virus infection. Now coming to the serological this findings. So this is not just the serological decoding table of hepatitis B. Serology is not data; it's the biography of the virus inside the body, and by this table you will be able to predict if the patient is infectious, immune, flaring, or hiding virus, and you can diagnose any HBV status instantly. Before dwelling into this, first let us see. HBsAg is surface antigen and is means virus is present, so it can be acute infection, chronic, and if present for greater than 6 months, then it's chronic carrier. HBV DNA tells us true virus replication, so treatment decision is based on this. Anti-HBC IgM means recent infection, acute or flare. So acute infection or flare based on anti-HBC IgM, whereas anti-HBC total means past or current infection, and HBeAg means infectivity marker. Anti-HBe means indicates seroconversion or recovery, for example in immune control phase, and anti-HBs means protective antibody, which means immune or vaccinated. So if patient is in acute infection, obviously he will have HBsAg positive, HBV DNA will be positive, and acute infection means anti-HBC IgM will be positive. There will be replication going on, but anti-HBs will be negative because there is no seroconversion yet. So if a patient comes to you with sudden jaundice, ALT much elevated, think acute HBV. Now what's this window period? Window period is when HBsAg is negative but anti-HBC IgM is positive and antibodies are still negative, and so only anti-HBC IgM is positive in window period, as you can see here. Only anti-HBC IgM positive antibodies, because in this window period antigens are not present, but antibodies, only single antibody has formed in this window period. What is resolved infection or vaccinated status? In this case anti-HBsAg will be negative but anti-HBC total positive, and anti-HBs will also be positive, so both core and surface antibodies are present. That means past infection recovered. So two antibodies, one is core and another is surface antibodies, are positive in resolved cases, whereas in case of vaccinated, this anti-HBs will be positive. So only anti-HBs positive means vaccine induced immunity, whereas if there is no, because when we vaccinate the individual we give him surface antigen, so if a patient has been naive to this infection, there has been no infection in the past and only he has received vaccine, then how come he will develop antibody against this core antigen? So to differentiate between vaccinated individual versus recovered past infection individual, so vaccinated will have only single antibody against surface antigen, whereas this will have both against core and against surface this antigen. The antibodies will have been formed. Now chronic infection means anti-HBsAg will be positive for more than 6 months, and obviously anti-HBC total antibody, for example IgG, will be positive, whereas in chronic infection anti-HBs is negative but infectivity is there. Infectivity can be present or cannot be present. Similarly this HBV DNA can be positive or cannot be positive, so it is, the action will be to decide the phase based on this, whether to treat or whether to monitor. Now how do we define flare? So if a patient has chronic HBV infection but there is sudden ALT rise and there is sudden development of anti-HBC IgM, so IgM reappears during flares of chronic HBV infection. It is seen in immune active or immune escape phases. As we already mentioned, there are 4 phases. One is immune tolerance phase, immune active phase, immune escape phase, immune control phase. So chronic HBV infection plus sudden ALT rise plus anti-HBC. So this can be seen in immune active phase or immune escape phase. Now what is occult HBV infection? In occult HBV infection, HBsAg will be negative, but DNA will be present. Antibody against core antibody will be present. So this is a hidden carrier, often missed before chemoimmunosuppression, because if it is missed, there is HBV reactivation. Thus it needs preemptive treatment. Now what is the difference between this chronic infection, active or inactive? You see, let's understand this war zone. As chronic hepatitis B virus is a dynamic battle between virus versus immune system over years or decades. So your job as a doctor is to recognize whether the battle is going on between virus or immune system or not. So is the liver under immune attack? If yes, then you have to treat. If not, you just have to monitor. So that's why we divide chronic HBV into 4 clinical phenotypes, as we have already described in our previous lecture. So that's why we divide it into immune tolerance, immune active, immune escape, and immune control phase. So in nutshell, immune tolerance phase is chronic inactive hepatitis. So this is anti-HBeAg is positive, but this is inactive, chronic inactive hepatitis, and you just have to monitor. This phase is not to be treated. Only 2 phases that are to be treated is immune active phase and immune escape phase, whereas these 2 phases are to be monitored because there is no inflammation, no liver injury, and immune system is not attacking it. That's why it's called chronic inactive hepatitis and called as chronic this immune tolerance phase, whereas immune active phase is chronic active hepatitis. So this is chronic active hepatitis because moderate to severe hepatitis is there and ALT is raised, and here liver is actively under attack and fibrosis will progress, whereas immune control phase is another phase that is called as chronic inactive hepatitis. In this, if you will see this tolerance phase and control phase, you will observe here HBeAg is positive but ALT is normal. DNA copies are more than 1 million, but EAG is positive and ALT is normal. In control phase also ALT is normal, but HBeAg is negative. So, and there is development of anti-HB antibodies here. So antibody against E antigen has formed, and DNA copies are less. Biopsy, it will show nothing, or it will show mild hepatitis, and action is you just have to monitor. It's not to be treated because virus is dormant here. There is no ongoing damage. How to catch this? Patient often looks healthy in this immune control phase and there is low levels of DNA. ALT is normal. Now what about immune escape phase? This is also chronic active hepatitis. In this there is precore mutant and biopsy shows moderate to severe inflammation. Why critical? This can be missed easily due to negative HBeAg, and that's why you have to look at ALT plus DNA. So single most important marker of liver injury is ALT, and inactive carriers, be it inactive carrier, we will say immune control phase. It can still This patient can still get hepatocellular carcinoma, so surveillance is needed, especially if age greater than 40 or family history if present. So if a patient walks into OPD, look at ALT plus DNA plus HbEAg and immediately know. Liver, if ALT is normal, liver is safe. If ALT is normal, if ALT is not normal, liver is inflamed. I need to stop this war. And also at HbEAg, you will decide whether virus is hiding or not. So as per this chronic infection, HbSAg will be positive, DNA will be positive, anti-HBc IgM will be negative, anti-HBc total will be positive, anti-HBG can be positive or cannot be positive. This depending. You have to describe this in phases, in 4 phases. Anti-HBs is negative. Please like and subscribe my channel.